of all, the question is, who is a poor responder? Who is a woman with a poor ovarian reserve? There is no clear-cut definition in the literature about who a poor responder is. The literature in assisted reproductive technology becomes a little difficult to analyze because they're not based on, many of them are not based on solid. It's a recent science and many of them are not based on solid definitions. When there are 40 different definitions in use and the number of cases that are done in any particular center are more like 30, 40 or 50, it becomes a little difficult to analyze these criteria that are published. And evidence-based medicine, like you've heard, becomes even more difficult in reproductive medicine. However, the first realistic attempt by the scientific community to standardize the definition of poor ovarian reserve in a simple and reproducible manner has been done now. And it's called the Bologna criteria. And what does the Bologna criteria say? At least two of the following three features should be met. At least first one is advanced maternal age over 40 years or any other risk factor for premature poor ovarian reserve, which can be something like an ovarian surgery or any other procedure being done on the ovary. A previous poor ovarian response, which may be defined as less than 3 oocytes, with a conventional stimulation protocol. Number 3 is an abnormal ovarian reserve test, and it may be any of the clinical tests that you have, and the most common being antral follicle count at the beginning of the cycle, which may be less than 5 to 7 follicles when both ovaries are put together, or an AMH which is very low. And this is the consensus by ESHRE working group on poor response, and it's a very recent definition. So, literature based on this is very few. Prior to that, numerous criteria has been used and no consensus was there. And the demonstrated previous floor outcome was anywhere between follicles 3 and 5. Oocytes that were obtained in a procedure between anywhere between 3 and 5. E2 levels anywhere between 300 and 500 picograms per ml. And a predicted poor response by a ovarian reserve testing, which is undefined. And you can see any number of different definitions over the previous years, which involved FSH, E2, oocyte numbers that were obtained, mature follicles that were there, age of the woman. However, the incidence of poor response we know in most of the ART units or infertility units is anywhere between 10 and 25% in patients undergoing assisted reproduction treatment. However, we can predict these with a certain number of other things as well. And the cyclic characteristics can be number of follicles and number of oocytes, as we've said. It can also be peak E2 levels. The amount of gonadotropins which was used during a previous cycle, if one had to use more than 300 IU of gonadotropins in a day, it usually is a woman with a poor response or poor ovarian reserve. Total dose of gonadotropins which was used in a previous cycle exceeds 3000 IU. Again, they come into the definition of a poor ovarian response. And if the starting dose itself had to be between 300 and 450, again they come into the same definition. Length of the gonadotropin stimulation, if it exceeds 13 days, again they come into this definition. Why does a woman become a low responder? What are the reasons that a woman becomes a low responder or has a poor ovarian reserve? Number one, of course, is aging. You've heard about it. Aging gives rise to exponential decline of oocytes in the ovary from 400,000 beginning of the reproductive life to about 400 at the end of the reproductive life, which means that this woman is losing several thousands every month. It's not the one follicle that you see which is being released. It's several thousands every month is what declines. And not only the numbers decline, there is a qualitative decline in the oocytes as well. But however, there is the determined timing of the aging is genetically determined. It is not an arbitrary age, it cannot be defined as an arbitrary age of above this age we consider them as poor responders, even though 40 has been thrown around. There are women where this decline starts much earlier in life. Even in the early 30s, there are women where the ovarian reserve goes down as early as 32 and 33. There are women where even at 43, you're successful in retrieving reasonable number of oocytes. So aging is the number one factor. The acquired risk factors are, one is increased BMI, which we don't even pay much attention to, but a woman who has a high BMI, generally her ovarian reserve is lower. Smoking, again, it is not unseen in even Indian metros today, that can decrease the ovarian reserve as well. Ovarian diseases such as endometrioma that you've heard about, and other ovarian diseases which require surgery, radiotherapy, chemotherapy can decrease the ovarian response as well. It's almost when I'm saying iatrogenic, when I say that, I mean things like PCOD ovarian punctures. You may not even consider this as ovarian surgery, because in an ART unit we are seeing more and more number of these cases, and they are becoming really concerning, is the reason I'm raising this issue. Now, a lot of places, a diagnosis of multifollicular ovaries is made by often a sonologist who's not even practicing obstetrics and has no concept of what the definition of criteria is, what exactly a polycystic ovary should be. It is just a diagnosis of multifollicular ovaries made by a sonologist and a cursory examination. And young women, the next thing you know, are subjected to a laparoscopic procedure and an ovarian drilling. Okay, and this is giving rise to a lot of problems now, where we are seeing more and more number of women, very young women who've been subjected to this procedure, who have decreased ovarian reserve too early in life following an ovarian burning, which was done totally unnecessarily. So we have to be aware of this. If this whole talk has one important slide, this is it. This is what we start out with: primordial follicles, primary, secondary, then it goes on to a dominant follicle and ovulated follicle. We all know what happens in the second half. To the right of that middle line, you know what happens. This is what we know, and this is what we follow, and this is what we try to manipulate. All of our gonadotropin and GnRH analogs that you've heard about apply to the second half of the cycle, and if you look at the numbers down below in the slide, you can see that for a single follicle to come from primordial to an ovulated follicle, it takes more than 120 days. So it's a process that takes 3 to 4 months for this process to happen, and the majority is the non-gonadotropin sensitive part, which is to the left of that line, where it becomes from primordial, primary, secondary and small antral follicles. It is not under the control of gonadotropins. Therefore, our ability to control this process is extremely limited, and that's the most important process. If you're starting out in a cycle in a woman with a small antral follicle, which is 3 in number, all of you do the antral follicle counts now for ovarian test reserve testing. If you're starting out with a small antral follicle, which is 3 in a woman, there is no magic that you can do to make that 3 into 10 ovulated follicles at the end of controlled ovarian hyperstimulation. So that is all you have, and that is all you're going to be getting. And a lot of times we get mixed up and start thinking that, okay, some combination of what you do with your ovarian stimulation agents, which is gonadotropin, and with GnRH analogs, in every woman we can make it possible to get 7, 8, 9 or 10. The ideal results of an ART cycle are obtained if you get at least about 10 to 12 follicles and 10 to 12 oocytes after stimulation. The best results are obtained if you're able to do that. But if you're starting out with 3, it's not going to be possible. So the left side of that middle line, what works is, what makes them go from primordial to small antral is usually growth factor, insulin-like factors, growth factors, and androgens. So these are inherent, these are paracrine factors, these are present in the ovary. These are the ones that move from the primordial follicles to small antral. Keeping that in mind, we look at what can we do to improve the outcome of an ART cycle or any other cycle that you do with a woman with a poor response. So the initial part of the cycle, the primary part, from primordial to primary, not much you can do. But beyond that, there can be synergy between FSH and androgens together. Beyond that, it is the gonadotropins that you control. So what all can we do to change the outcome in a woman with a really poor result? Okay, and what is left to us is controlling on the right of that line by manipulating the gonadotropins, where I told you that not too much can be done, but at least you can try to get the optimal results out of whatever this woman already has. And the things that we are playing around with is gonadotropins and GnRH analogs, both of them to get the optimal outcome out of this woman. And the first thing that one tends to do in a woman with poor ovarian reserve is increasing gonadotropin dosage. Where if we are starting in an average patient between 200 or 225, or some do even with 150, people used to go up to even like 400 IU or even 450. 600 IU per day in an attempt to get these follicles to grow. But you cannot really manufacture follicles de novo. It is not manufactured by gonadotropins, and it can only support the cohort of follicles which are actually there and receptive to stimulation. And it's been proven with prospective studies now, with low AFCs, it doesn't matter what the dosage of recombinant FSH you use. There is not much of a difference in the number of oocytes that are recruited, pregnancy rates, or cancellation rates. So using super high levels of gonadotropins is actually not effective strategy in these women. I think that is something that majority of units have now given up. They use a standardized dose, whatever their dosage is, even with women with poor ovarian response. So increasing the total number of gonadotropins or per day dosage of gonadotropins actually has no role to play. How about then modifying how you use the gonadotropins? So increasing dosage of gonadotropins beyond a certain extent loses its effect. Doesn't matter what kind of gonadotropins to use. There is recombinant gonadotropins in the market which are several times more expensive than urinary gonadotropins. Does it really give rise to a higher pregnancy rate? Increase in number of oocytes retrieved, increase in pregnancy rate, it is decrease in cancellation rates, has been reported with recombinant FSH. But a lot of us in IVF units do use recombinant for several other reasons, because it's easier to titrate doses and it's very sure to be about the standardization of the FSH that is present in the ampule, which is with urinary gonadotropins becomes very questionable now. If the cold storage is not okay, if the standardization is not okay, the response is unpredictable. Therefore, a lot of us have moved over to recombinant also because of the fact that we may not even be getting urinary gonadotropins in the market for a longer period of time. I think the nuns of Europe do not supply the menopausal urine much longer. So there is a very huge dearth of gonadotropins, urinary gonadotropins in the market. But that is actually whether it gives rise to better oocytes, a better number of oocytes, we're really not sure. Luteal administration can be done before the cycle. Again, no increase. Results are not increasing. The luteal is started early, so maybe you can recruit more follicles into the waiting pool. Again, it has not been proved. And thus, supplementation of LH increase. LH used earlier on in the cycle increases the local androgens, which is usually supposed to decrease with age. So there are some papers suggesting that in women over 38 years, when recombinant LH was used, the implantation rates varied. How else can you change the GnRH analog manipulation? GnRH antagonist, you decrease. GnRH antagonist is like stop. Okay, decreases the ovarian function, and then you use gonadotropins to get the follicles to grow. This is used primarily to stop the LH surge from happening prematurely. LH surge and the cycle being ruined, happening prematurely. And people have used half the dosage of GnRH analogs. GnRH analog stop protocol, you use it in the previous cycle and then you stop it and start your stimulation. And GnRH analog flare protocol, we use it initially. So therefore the flare that happens with the GnRH analog agonist also helps with the gonadotropins, but none of them have shown to be effective in these protocols. The only protocol in GnRH agonist that has made even a slight difference is microdose flare, where the oral contraceptive is used for 21 days, followed by leucolytic acetate 20 to 40 units day 2 and 3, and gonadotropins to be started 1 to 2 days later. Advantages being ovarian suppression in that kind of a minimal dosage is not excessive, and the aim to achieve gonadotropin release while eliminating the phenomenon of increased LH, androgen and progesterone secretion noted in the classic flare protocols. So microdose flare, the flare lasts only for 3 days. E2 increases more than mature number of follicles, increased number of oocytes. When there are large prospective randomized control studies, which are still required, but then whatever is in the literature suggests that there is a trend towards improvement when you use the microdose protocol. What about the antagonists? Leaving the agonist, you go for antagonists. Antagonists, are used only in the second half of stimulation. So the first half of stimulation, there is no down regulation. There is no lack of separation in the beginning of stimulation. And the use of endogenous gonadotropins in the beginning, which is not suppressed. The follicles are recruited in a more physiological milieu, but subjected to LH deprived environment later part of the cycle. So there are many things which are good about it, some things which may be a little bit of a problem. And here, addition of antagonists, several studies are published in the beginning of antagonists being introduced. In the beginning, the results were slightly lower, but however, in the poor responder group, now the majority of people feel that there will be better results when you're using antagonists rather than long down-titration protocols. OCP treatment prior to antagonist cycles significantly reduces ongoing pregnancy rates. Androgens which are used pre-treatment, this is where your DHEA comes into play as well. Pre-treatment of the either recombinant LH or DHEA, which is being widely used now, which can, or it can be letrozole used, which is blocking intra-ovarian androgen conversion, still no improvement in pregnancy rate. So androgen is supplemented by either DHEA given for 3 months prior to the procedure, testosterone patches just prior to the procedure, gels, and these are still very much underpowered studies, and they really have not suggested that the pregnancy rate has improved. DHEA, there's a very recent published article, good controlled study, randomized controlled study, which has not shown much of a benefit by using DHEA. What about use of growth hormones? It has a facilitator effect, it stimulates E2 production, enhances nuclear and cytoplasmic maturation, may have a positive role in increasing total cell number in embryo and reducing apoptosis, and it has a stimulatory effect in DNA repair as well. And the pooling of the data so far concludes that addition of growth hormone increases the probability of live birth by an odds ratio of 5.22, which is very significant. Addition of GHRH has not shown to do much of a difference. Addition of pyridostigmine, again there are articles, no difference in pregnancy rates. Addition of L-arginine, addition of glucocorticoids, none of them have been shown to increase either the oocyte yield or pregnancy rates. And current evidence does not support the use of low-dose aspirin, and I guess no molecular weight where heparin goes without a definitive need for it. These agents do not give rise to increased pregnancy rate. The other alternative is minimal stimulation protocol. If your stimulation doesn't give you enough number of oocytes, you might as well go to either natural cycle or minimal stimulation. And that can be done either in a natural cycle or a clomiphene with gonadotropin. The results are lower, but something called oocyte pooling can be done. You don't do the entire procedure. You just subject them to gonadotropins and minimal amount of gonadotropins and clomiphene, retrieve the oocytes and freeze the oocytes and do your oocyte pooling, and then ICSI at a later stage. This has cumulative pregnancy rate in some studies are reported to be good, but not everybody who's tried this protocol is extremely happy with that either. So finally, we come to some recommendations only. Microdose GnRH agonist flare-up regimens have been shown in the literature to have an advantage, at least small amount of advantage. Use of antagonist cycle is the standard protocol in the majority of units at this point in time, and some do use the luteal estradiol pre-treatment as well. Addition of LH alone or LH containing gonadotropin initial part of stimulation can increase intra-ovarian androgens and can have a benefit effect. Growth hormone supplementation if the patient can afford it. These are the strategies which have been shown to have at least a minimal amount of positive effect. But however, there is insufficient evidence still to support the routine use of any particular intervention, either for pituitary ground regulation, ovarian stimulation, or adjuvant therapy in the management of poor responders to control ovarian hyperstimulation. More robust data is needed from good quality RCTs with relevant outcomes. So is there light at the end of the tunnel? Very little at this point still.